Good morning, afternoon, good evening, everyone. Welcome to the APASL School e-learning seminar series 2 called How Do I Do It in Hepatology? Session 1, Paracentesis. I'm Professor Hasmik, Ghazinian, Yerevan, Armenia. And I will be co-moderating the session with Professor Gamal Shiha from Egypt. The session has 3 talks, and my pleasure to introduce to you first speaker, Professor Guru Aithal, who will be presenting on indications, contraindications, checklist procedure, prevention and prediction of bleeding, local complications of paracentesis in liver disease patients. Professor Guru Aithal is the professor of hepatology and the head of Nottingham Digestive Disease Center, University of Nottingham. He leads the gastrointestinal and liver disorder team of National Institute for Health Research, Nottingham Biomedical Research Center. Please, Professor.
Thank you. Hi. I will share the screen. Just make sure that it's coming in full. Okay, can you see it well now? Are you seeing full screen or are you seeing the
half screen?
Half screen. What about now? Is that good?
Yeah.
Yes. Yeah, okay. Hi. As you have heard, I'll be talking about the indications, contraindications, checklists, procedures, and risk factors, and how to prevent local complications in patients with cirrhosis in particular. So, when should you do paracentesis? There are 2 times when we sample or drain acidic fluid. Diagnostic paracentesis, the indications are, first of all, in any inpatient. If you look at patients with cirrhosis with ascites, incidence of spontaneous bacterial peritonitis is about 1.5 to 3.5% when they are in outpatient. But in hospitalized patient, it's nearly 10-fold, 10 to 11%, even with the most updated information. And there is also data to suggest that each hour of delay of diagnostic paracentesis and treatment is associated with 3.3% increase in in-hospital mortality. So if patients are admitted to hospital for any reason at all, it's an indication to do diagnostic paracentesis. And suspicion of spontaneous bacterial peritonitis should be at the lowest threshold possible. If they have got GI bleeding, we already give antibiotic prophylaxis with the assumptions that they are going to get SPP if they have ascites. Any unexplained shock, any systemic signs of inflammation, any GM symptom at all, or worsening liver or renal functions, even on tests, or hepatic encephalopathy. Any of these can be considered as an indication to do a diagnostic paracentesis. And once you diagnose it, you should implement treatment as soon as possible. In the outpatient, the first time when you see ascites, again, was always a need for doing diagnosis. And unlike previously taught, ascites and its etiology behind them are really widening. In the past, people used to say that 85% of ascites is due to cirrhosis. Even in the West, it's not so. The latest data from UK shows that maybe 55% of all ascites coming to first time are due to cirrhosis, which means that rest of the 45%, there are alternative explanations. So diagnostic paracentesis is even more important. When do you do therapeutic paracentesis? This is mainly symptomatic treatment. Remember that. It can be abdominal symptoms. It stretches the abdomen and causes discomfort and pain. Might really reduce appetite because it presses on the stomach and reduces gastric emptying. Breathlessness is common with ascites because diaphragm is pushed up, or you might have associated pleural effusion. And mobility, people are carrying extra weight, 10 kilograms or more, and that overall reduces quality of life. But keep in mind that therapeutic paracentesis, if you're done only due to symptomatic relief, it is temporary. You will need it on an average at least once in 2 weeks, sometimes even faster. It does not resolve the fluid retention. If you have got lots of edema, abdominal wall edema, remember that it's not a solution for the problem. And even when you do it very well, there is still significant residual percentage of post-paracentesis circulatory dysfunction. So it's not without a problem, even when it's done well. The second indication for therapeutic paracentesis is refractory ascites, when medical treatments either don't work or there is intolerance to this. So contraindication for diagnostic and even therapeutic paracentesis are relative. There is no absolute contraindication because diagnostic paracentesis, as I said, is indicated many times to life-saving interventions, and also the complication rates are low. Symptomatic relief of ascites is mainly to improve quality of life. So you should really balance always the indications with contraindication. I would say people having disseminated intravascular coagulation is one of the contraindications. And rising creatinine, either associated with SPP or hepatorenal syndrome, is again a relative contraindication. And standard therapeutic paracentesis may not work and might be associated with more complication when there is loculated ascites. So these are the relative contraindications. Checklist, what will you need? In a diagnostic paracentesis, you need to be prepared for the tests. We have recommended in a recent British Society of Gastroenterology and British Association for the Study of the Liver guidelines that we need to take informed consent. It doesn't say that written consent, but they need to understand pros and cons, benefits and disadvantages. We prefer ultrasound guidance. It doesn't mean that it has to happen in radiology. We just put a probe onto the tummy and find out where the depth of fluid is and ensure that there is no bowel loops coming in a way. Sterile precautions are standard. You have swabs and drapes, and you have local anesthetic even for diagnostic paracentesis. And we use different kinds of needles for the skin, thinnest needle, and then peritoneum injection, we use a little bit bigger needle. And if you want to aspirate, then even bigger needle. And you need to have tubes. This is particularly the pictures are put on the guidelines because people have conventionally taken a tube which is a sterile container. But if you need a diagnostic paracentesis reports very quickly, you can put it into EDTA bottle and it will be going through the auto analyzer just like a white count. It really records white count and neutrophil count, and you can use that for the diagnosis of SPP. In patients who are suspected to have SBP, or you are doing for an indication where cirrhosis is already known, then you inject fluid into the culture bottles at the same time at the bedside. The devices, I must say that none of these are yet purposely designed devices available. One at the top is called Rocket, which is often used, but it's again multi-purpose device. One at the right side bottom is a device which we are designing specifically to do paracentesis called Melody. I think this is a decision to be made by individual centers as to what they want to use. Banana catheter used to be the common one used, but it's designed for suprapubic cystostomy, so it's not really a very good device to use. What are the risk factors for complications and what one would consider to reduce complications based on evidence? These data comes from a systematic review of paracentesis. Complications are low, even with therapeutic paracentesis. Overall reported data from larger studies, which I have cited here, is about 0 to 2.5% for bleeding. Fluid leak is quite common, and 2.5% again. Perforation rate is less often reported. It's possible that anecdotal perforations aren't really reported often, but when there is perforation, it's often the bowel perforation rather than a solid organ perforation that are reported. Is there a role for ultrasound guidance? If I say use the ultrasound guidance, means that check the safe site to do a paracentesis, there is some data to show that it has got less frequency of complications. So there are two bigger studies that I have cited here. One of them had 1,297 procedures, where almost half of them done with and half of them without ultrasound guidance. Numerically, incidence of adverse events were lower in ultrasound guidance. Another study where ultrasound guidance was used in some and not the other, overall 565 procedures, 0.8% had bleeding complication, and ultrasound guidance was associated with 68% less bleeding rate. And the middle line, I have highlighted that it's common for these patients to have high MELD score and high INR, up to 7 in the range of MELD score up to 40 MELD score. If you take the large cohort of 3,116 procedures, only 7 bleeding complications were seen, of which 6 required transfusion and 1 required embolization. So it's pretty reasonable procedure to do as long as common approaches and sensible precautions are taken. Landmarks are something to keep in mind. The primary complication, as I mentioned, is bleeding. So you need to avoid obvious vessels. So the landmarks in the picture here shows inferior epigastric artery and the rectus muscle. You need to keep that in mind. And if you do an ultrasound, there is one study I have cited here where 52 patients, 15% of patients with obesity had an ultrasound before paracentesis, and they demonstrated the left lower quadrant, as they defined 2-finger breadth cephalad, a 2-finger breadth medial to anti-superior iliac spine. You had the thinnest wall and the deepest collection of fluid. So I would say left lower quadrant is preferred site of paracentesis, both diagnostic and paracentesis, as well as therapeutic. For the reasons mentioned, avoid rectus muscle, which is thicker obstruction in the center, and avoid inferior epigastric artery. So what would I do? I do not measure routinely platelet count and prothrombin time, which is not evidence-based. We do not correct abnormalities by giving blood products. We recommend, based on, again, data from CTs done in people with obesity, as well as laparoscopy, 5 centimeter above the pubic symphysis, 8 centimeter lateral is the site to do. And just ultrasound guidance shows that on the left-hand side, the figure shows that there is a deepest amount of fluid there. So ascites can be developed as a day case service. So who should be doing it? There is abundant data to show that it can be done by our allied clinical professionals. GI endoscopy assistants or specialist nurses can do it effectively and safely, and they need to be supervised for 10 procedures to achieve competence. And this is the data from 1,100 procedures, almost all done by allied professionals. They had a mean duration of 1.5 hour or so, up to 2 hours to complete the therapeutic paracentesis, about 8 to 10 liters drained. And in these procedures, mean INR was 1.7, median platelet count was 50, and there were no procedure-related problems which were reported in 1,100 procedures in this service. So there is evidence to show that day case ascites paracentesis service reduces emergency admission to hospital for ascites-related symptom and drainage. And there is one feasibility randomized controlled trial which has just been published a few months ago. There are a small number of patients who are unsuitable for transplantation, but do not want to come to hospital or even day case unit for repeated paracentesis because of both social as well as physical factors. In these, you can put in a long-term drain. In this study, they gave prophylactic antibiotic and kept the patients on antibiotic for their lifespan. They reported about 41% had self-resolving superficial cellulitis, but they didn't have any major complications other than that. They demonstrated that this is feasible and reduces cost by reducing hospital visits and hospitalization. But this is yet to be demonstrated in a large randomized controlled trial. So overall, take-home message is that diagnostic paracentesis, first of all, recommended in every patient who had ascites is presenting as the first manifestation. 2, in patients wherever they are inpatients or SBP is suspected for even the lowest threshold, you need to do it as quickly as possible so that you can improve survival in hospital. Routine measurements of prothrombin time and platelet is not indicated, and blood product is not indicated. If you can get an ultrasound guidance, it's desirable. Left lower quadrant is preferable site, and you can develop a service based on allied health professionals. And there is some feasibility data to show that you can keep a long-term palliative drainage in situ to relieve patient symptoms in the long term. And these are the 2 references. British Society and British Association for the Study of the Liver Guidelines is published January issue, and there is a blog linked to it, and both are free to access for anybody who is participating or even outside this group. Thank you.
Thank you, Professor Guru, for your the interesting and informative presentations. I would like to introduce second speaker, Professor Ayman Alsebaey. His talk is managing the bleeding local complications during paracentesis. Dr. Ayman is Associated Professor of Hepatology and Gastroenterology, National Liver Institute, Menufia, Egypt. Please, Dr. Ayman.
Thanks a lot, and thanks a lot to Professor Guru. Your lecture was very interesting for me. Today, I will speak about the complications of abdominal paracentesis. Okay. And I want to say that the literature are not so much, and this is a sign of safety of the maneuver. And the data are obtained from the literature and from unpublished data from National Liver Institute. As we know that large volume paracentesis is a method of rapid relief of ascites, so it is used mainly to treat tense ascites and refractory ascites. And it is a safe outpatient maneuver that can be done by specialized nurses, by endoscopy assistant, and by the physicians. We know that there are 2 sites for the paracentesis. The preferred one is the left lower quadrant because there is thin wall and deeper extent of the ascites. We can classify the complications of ascites into 3 categories: immediate during the maneuver, later on develops like PICD, paracentesis induced circulatory dysfunction, and we will focus on the local complications related to the maneuver like bleeding, leak, infection, perforation, and organ injury. If we go back to the history, you will find that there is a famous composer called Beethoven. We all know him. This composer at the end of his life had respiratory failure, cardiac failure, and liver cirrhosis, and he needed paracentesis. He underwent 2 sessions of paracentesis. The first one was 11 liters acetic tab, and the second one was 22 liters of acetic tab. When he saw the acetic fluid comes up from his abdomen, he cried and said, "This remembers me of Prophet Moses, peace on him, who struck the rock with his staff and the water gushed forth." Unfortunately, 3 complications occurred to Beethoven. The first one is infection of the puncture site. The second complication is persistent leak, and the third complication was this. This is a nice study which was published in 2009, and it discussed the complications of abdominal paracentesis. It included 170 patients who underwent more than 500 tapping. Most of the maneuver was blind, 90%, and 10% was ultrasonography guided. The puncture site, it was mainly in the left lower quadrant. Here you will find that the 90% of the patient had safe maneuver without complication, 10% had complication, and 9% who had mainly minor complication, so paracentesis is a safe maneuver. The common complications were perforation, infection at the puncture site, acetic fluid leak, and bleeding. The leak in this study, most cases had self-limited leak management, and few cases needed a stoma pouch. Regarding bleeding, it was minor in about 2.3% of the patient, and only 5 patients needed major intervention by chemoembolization. In this study, unfortunately, 3 patients died. We should focus on this because during the maneuver, bleeding and perforation of the viscus occurred, sepsis occurred, and they died at last. So the mortality was found in 3 patients, or 0.4%. In this study, they said that there are patients' risk factors for complication, patients who had advanced liver disease, especially child type C, and when you are doing therapeutic paracentesis compared to the diagnostic one, if the etiology of the cirrhosis is related mainly to alcohol intake and the platelet count less than 50,000, okay? The immediate complications which may occur during the paracentesis are simply the patient may develop hypotension. There was a nice study done in 85. They found that if you do paracentesis less than 5 liters, there is no change in the plasma volume measured by the isotope scanning, and there is no change in the electrolytes or the blood pressure or even creatinine increase. But of course, if we are doing a large volume paracentesis and you remove a lot of fluid from the patient, hypotension may occur, especially if the patient is on antihypertensive like beta blockers or any antihypertensive drug, okay? And if we are doing rapid tapping, okay, cramps may occur during paracentesis, and it is a sign of hypovolemia. At the end of paracentesis, hyponatremia and hypokalemia may occur, especially with large volume more than 10 liters. The first dangerous complication we always face is bleeding. Before we say what is the bleeding, we should revise the anatomy. If we revise the anatomy, you will find that the rectus muscle at its lateral border, there is an important artery, which is called the inferior epigastric artery. It is commonly injured in the past, so guidelines say don't come near to the lateral wall of the rectus muscle. Recently, they discuss the new artery, which is the deep circumflex iliac artery, which runs parallel to the inguinal ligament, okay? So if we revise the newest British guidelines, they say go 5 centimeters above from the symphysis pubis and in centimeter lateral from the umbilicus. Here you will be away from the deep from the inferior epigastric artery and from the deep circumflex artery. Okay, this does not mean that this area of the flank is devoid of arteries. No, we may have lumbar arteries, but usually their injury is difficult. When you find during paracentesis blood coming out in your line, you should ask yourself first, did I injure the patient or from the start he has bloody ascites? Simply to answer this question, take another sample from the opposite flank. If it is bloody, the patient has bloody ascites from the start, maybe due to ruptured hepatocarcinoma and so on. The second point that the ascitic fluid is rich in hyperfibrinolytic system. So if you take a sample, it will not clot. But if you injure a blood vessel, you will find that the blood coming in the line, it will be dark reddish and it will clot within the line. This is very important way to differentiate between if the patient has a blood ascites from the start or did I injure the patient. The literature said that there are risk factors for the occurrence of bleeding. Any patient with renal impairment or advanced liver disease already has high liability for development of bleeding. Sometimes the maneuver itself may be the cause, especially if I am losing large needle or I didn't use the puncture site well. If you puncture in the midline, which is rich in sub-abdominal wall collaterals and varices, you will injure the blood vessel. If you put your puncture beside the rectus muscle, you will injure the inferior epigastric artery. So choosing the choice of the puncture site is important to avoid the bleeding. Also, if the patient has IVC, thrombosis, and collaterals on the flank, it is easy to puncture these collaterals. The presentations of the bleeding, it may be in the form of half of the patient will have hematoma at the site of the puncture site, and 40% will have hemoperitoneum. The blood, it will be spurred into the ascitic fluid. Few cases will have retroperitoneal bleeding. The patient, he will suffer from pain at the puncture site. If the bleeding is major, there will be drop of the blood pressure and there will be drop of the hemoglobin. Okay, we should know that bleeding, it may occur early during the maneuver and it may occur later on for delayed bleeding. How should I deal with bleeding? Fortunately, most of the cases are managed conservatively and the bleeding will stop spontaneously. But few cases will need intervention, and the type of the intervention is always radiological because surgery is associated with high mortality. If we look here to this CT, you will find that there is this hyperdense area is a hematoma in the anterior abdominal wall due to injury of the inferior epigastric artery. This case is funny. He underwent ultrasonography guided paracentesis and unfortunately he injured the deep circumflex iliac artery. Here you will see the hematoma more obvious in the coronal section. This patient underwent paracentesis, but after 4 days he had pain. They found that the bleeding mainly was retroperitoneal due to injury of a blood vessel. Here, another case, you will see that this dot is the blood vessel and this is the blood is coming out from it and it was managed by gel foam injection and embolization, another case of abdominal wall hematoma. I should ask myself, should I have coagulation profile before the maneuver or not to avoid bleeding? The first study done here, they said that the prophylactic plasma transfusion, fresh frozen plasma, did not alter the bleeding risk. In another study in 2004, they found that, which included large number of patients, they found that there was no increased risk of bleeding despite patient had very low platelet count up to 19,000, prolonged INR up to 7. The absolute contraindication and for the maneuver is the presence of DIC. The British Society of Gastroenterology recommended the following. Routine measurement of the prothrombin time and the platelet count before therapeutic or diagnostic paracentesis and infusion of the blood products are not recommended. The other point I should ask myself, should I use ultrasonography to decrease bleeding? This is a nice study done in 2013. It included equal number of patients, 3,000 and 3,000. Here the maneuver was blind and here it was ultrasonography guided. They found that patients who underwent ultrasonography guided maneuver had lower risk of bleeding and lower rate of complication. I searched for guidelines for such point. I found that this was the recommendation on the use of ultrasonographic guidance by the Society of Hospital Medicine. They said that number one, ultrasonography, it decreases the risk of bleeding. It is very useful for small volume ascites because it tells you the nature of the ascites, the volume, and the best site for puncture. You can use Doppler before piercing the abdominal wall to avoid blood vessels. This is very important. And there are two methods for introduction of the needle, by marking or by using real-time ultrasonography guidance. Again, the British Society of Gastroenterology said, if you have ultrasonography machine in unit, use it for as long as possible. Ultrasonography guidance should be considered when available during large volume paracentesis to decrease the risk of bleeding. Now we come to another point, which is leak. Leak is a disgusting complication of abdominal paracentesis, which causes soiling and soaking of the pads and the clothes. There are factors related to the patient, and there are factors related to the maneuver. If we look to the patient, any patient who have abdominal wall edema, he easily will develop leak because there is free fluid in the subcutaneous tissue. Also, malignant ascites may be associated with leak. But what is about the procedure? If the patient is having tense ascites and you did for him small volume paracentesis, it is easy to have leak because the pressure inside the abdomen is still high. Also, if you did not use the Z technique for piercing the abdominal wall, incidence of leak is very high. And also, after paracentesis, the patient should lie on the opposite side and the orifice of the paracentesis towards the sky to allow clotting of the tract. Okay, how should I manage leak? Simply, number one, if the patient underwent small volume paracentesis, you should do large volume paracentesis with albumin replacement and using diuretics. This is first one. There are multiple options in the literature by using suturing, for example, by the usage of histoacrylate injection, by the usage of what is called fibrin glue injection, and the autologous blood patch, and at last, if all the lines fails, you need a ostomy bag. Here, the first method, if the conservative treatment does not work, is to use histoacrylate. There are two methods for using histoacrylate. Make the patient lie on the side and the orifice towards the sky, dry the skin completely, put histoacrylate on the surface, and use nasal bronchs to release oxygen so polymerization can occur. The other method that you can inject the histoacrylate using the insulin syringe into the subcutaneous tissues. This is a very nice idea. Another idea is the usage of the autologous blood patch. This technique is used mainly for closure of leaks after CSF samples and after thoracentesis. Simply take 10 to 30 centimeters of the patient's own blood, then you have to inject it into the subcutaneous tissue and the muscle. It will cause compression of the tract and the leaks will stop. If we look here, this is the orifice and this is the leak coming out from it. Here, if the size of the orifice is decreased markedly, then it disappears. The changes in the color here is related to hemolysis of the blood. It is a safe maneuver without side effect, just the vein as the injection of the blood. Also, we may use suturing of the anterior abdominal wall. It is better to use purse string suture, okay, and also figure of 8. If it failed, all failed, you just put ostomy bag to avoid soaking of the clothes. What is about fibrin injection? It is useful, but it may be associated with hypotension and anaphylaxis, so try to avoid it. We will come to the last point, which is organ injury. Can I injure an organ during paracentesis? Yes. For safety, the patient should void his bladder before paracentesis, okay? This is very important. If the patient is pregnant female, you should use ultrasonography to avoid injury of the uterus. And some societies may refer to do X-ray before the maneuver to say if there is perforation before maneuver or not, because any paracentesis will be associated with innocent pneumoperitoneum. In the literature, I found only 2 cases. The first case is a splenic laceration, which is obvious here in this city. She was female patient with HIV and end-stage renal disease. She underwent paracentesis from wrong side. Instead of using the left lower quadrant, they used the left upper quadrant. Unfortunately, the patient developed severe pain and laceration of the spleen occurred. In the other case, it was perforation of the ascending colon. This patient had refractory ascites and they decided to fix indwelling catheter for drainage. Unfortunately, after 24 hours, the patient developed pain and they found that there was perforation of the ascending colon. Infections. Infection, it was common in the past before the application of the antiseptic techniques, but nowadays it is rare. The only one which may occur that during paracentesis you may injure the intestine and the contents of the intestine comes out with a cystic growth, but healing it occurs rapidly due to the momentum. So it is a case of an adherent perforation of the bowel by the paracentesis needle. Don't do anything, just repeat. Take another sample after 24 hours. If neutrophilia occurs, you should give antibiotics, broad spectrum antibiotics covering the gram-positive, gram-negative, and anaerobes. The last slide is about foreign body reaction. Yes, in the past, this is a case published in 78. They found that after paracentesis in a critical patient, the plastic part of the needle was lost inside the abdomen. Unfortunately, they could not do surgery for extraction because the condition was critical, and at last the patient died. Thanks a lot for listening.
Thank you, Professor Ayman, for your excellent presentation. I would like to introduce next and finally last speaker, Professor Vinod Arora. His talk is prevention of paracentesis-induced circulatory dysfunction. Professor Arora is Assistant Professor, Department of Hepatology, Institute of Liver and Biliary Sciences, New Delhi, India. Please, Professor Arora.
Good evening, everyone. I'll be talking about today prevention and the management of paracentesis-induced circulatory dysfunction, that is PICD. I'd like to thank Dr. Manoj, Dr. Sareen, and APASL for providing me an opportunity to present here. I have none financial disclosure and no conflicts of interest. Ascites has an annual incidence of 5 to 10% in patients with compensated cirrhosis, and usually the incidence of refractory ascites reaches up to 10% annually in patients who have ascites. Transplant, large volume paracentesis, and TIPS usually remains the viable option for the management of refractory ascites. Goal of paracentesis is basically to provide immediate relief and to prevent PICD. PICD traditionally has been described after large volume paracentesis and has been associated with a faster reaccumulation of ascites, hyponatremia, renal impairment, and shorter survival. PICD traditionally is defined on the basis of the plasma renin activity, increase in plasma renin activity 6 days after the paracentesis of more than 50% of the pre-treatment value to a value greater than 4 nanogram per ml per hour. And the incidence ranges in patients who have been tapped without using any plasma expansion up to 80% and decreases to 11 to 20% who receive plasma expansion using albumin. Earlierly, it was thought that the PICD is secondary to the abrupt reduction in the intra-abdominal pressure post-paracentesis, leading to the extravasation of the fluid from the intravascular compartment to the peritoneal cavity. And the reduction of the plasma volume leading to the activation of the vasoconstrictor and the enteronephritic system, promoting sodium and water retention, leading to dilutional hyponatremia and renal failure. However, study by Salo et al. On 25 cirrhotic patients showed there was no change in the transvascular escape rate of the albumin or transvascular extravasation of the albumin in patients who had PICD versus who didn't have PICD. There were no lack of changes in the plasma volume and microvascular permeability seen after the paracentesis. So it was thought it is the reduction of the effective blood volume which basically drives the pathogenesis of the PICD. This study in 13 patients who underwent paracentesis without colloid shows the neurohormonal changes in the central pressures with paracentesis. There's increase in the plasma renin activity, which was initially noted after 24 hours of the post-paracentesis. Similarly, for the aldosterone level, there was initial decrease followed by increase, which was noticed post-paracentesis 24 hours after the TAP. Similarly, for the atrial natriuretic factor, there's initial increase followed by a gradual decline, which was noted at 24 hours. So, the pressure, pulmonary artery pressure, pulmonary capillary wedge pressure, and the central venous pressure decline gradually over post 24 hours post paracentesis. The interesting point which was noted in patient who had peripheral edema, they didn't had such severe reduction in the central venous pressure as compared to the patient who didn't had edema. There was a gradual decline in the central venous pressure which was noted with paracentesis. This shows the modification of the intra-abdominal, intrathoracic pressure, showing gradual decline with the paracentesis. There was also decline in the pulmonary capillary wedge pressure and the right atrial pressure post-paracentesis, which were maintained when the albumin infusion was started. This basically shows the similar changes in the mean arterial pressure. There was a gradual decline followed by which maintenance after the starting of the albumin infusion. Similar effect was seen on the stroke index. The inverse correlation has been seen between the systemic vascular resistance and the plasma-renin activity. Higher the increase in the plasma-renin activity, and the greater is the decline in the systemic vascular resistance, which is noticed. There's an inverse relation between the changes in the plasma-renin activity and the systemic vascular resistance. Abdominal decompression has been studied for its role in PICD. It was done by Cabrera et al. On 11 cirrhotic patient, and basically when the intra-abdominal pressure was maintained using a girdle, there was no change in mean arterial pressure, right atrial pressure, cardiac output, or systemic vascular resistance was noted. However, once the girdle was deflated, there was a decline in mean arterial pressure, right atrial pressure, increase in the cardiac output, and the decline in systemic vascular resistance, which was noted. Hemodynamic effects of paracentesis usually appear even immediately after the removal of first few deciliters of the fluid, and the greatest hemodynamic occur after the removal of 750 ml of fluid. The ascites removal usually induces two opposing and simultaneous effect. One is beneficial owing to the mechanical decompression of the inferior vena cava and the reduction of the thoracic pressure, leading to improvement in the cardiac output and systemic hemodynamics. And there's a deleterious effect, that is mechanical decompression of already dilated splanchnic vascular bed, promoting further arterial vasodilatation in patients. To summarize, a patient with cirrhosis usually have a pre-existing arterial underfilling, and once they undergo large volume paracentesis, there's a decompression of the splanchnic vascular bed, there's splanchnic vasodilatation, and decrease in systemic vascular resistance, promoting decrease in arterial filling, leading to the activation of the neurohormonal and the RAS system. There's an increase in nitric oxide levels, increase in intrahepatic vascular resistance and hepatic venous gradient, promoting rapid returns of ascites and renal failure, and PICD, which is usually not spontaneously reversible and has been associated with high mortality. Coming on how to prevent a PICD, that is plasma expansion versus vasoconstrictors. This was a randomized controlled trial in patient with who underwent therapeutic paracentesis with or without albumin infusion. The patient who had albumin infusion, there was a lesser incidence of hyponatremia or renal impairment. The patient who didn't have albumin infusion during the paracentesis had a higher incidence of hyponatremia, renal impairment. Similarly, the study by Loka et al. Studied the changes in the neurohormonal renal functions and hemodynamic with paracentesis. They basically showed at 24 hours post paracentesis, there's an increase in the plasma-renin activity and the aldosterone level, which was significant as compared to the baseline noted. There was a decline in ANF level post 24 hours paracentesis. Similarly, there was a decline in sodium level, decline in pulmonary artery pressure and pulmonary capillary wedge pressure, and cardiac index 24 hours post paracentesis who didn't receive albumin. This basically shows the changes in the cardiac index and the pulmonary capillary wedge pressure with albumin post paracentesis. The patient who received albumin maintained the cardiac index and the pulmonary capillary wedge pressure. However, the patient who were tapped without using albumin, there was a decline in the cardiac index and there was a decline in the pulmonary capillary wedge pressure 24 hours post-paracentesis. Albumin has been compared to the other plasma expander, dextran and polygilin. This was published in Gastroenterology 1996. And albumin patient who received albumin and underwent paracentesis had a significantly lower incidence of PICD as compared to the patient who received other form of colloids. Similarly, the incidence of complication that is AKI or hyponatremia was higher in the patient who received other albumin. Albumin has been compared to the saline in prevention. PICD occurs significantly higher in patient who received saline as compared to albumin. And however, no significant difference was seen in the volume of fluid removed for less than 6 liters. Albumin has been also studied in the standard, that is 8 gram per liter versus 4 gram per liter of the volume of fluid removed. The incidence of PICD, hyponatremia, and renal impairment were comparable between the two groups. This was a large meta-analysis using the albumin infusion in patient undergoing large volume paracentesis, which included 17 randomized controlled trials, including 1,225 patients, and other vasoconstrictor which was used in the study were namely midodrine, terlipressin, noradrenaline. As compared to no treatment, albumin basically reduced the odds of developing PICD by 93%, 61% when compared to the any other plasma expander, 30% when compared to any other vasoconstrictor. Albumin decreased the incidence of PICD with the odds ratio of 0.39 and decreases mortality with the odds ratio of 0.64. Terlipressin has been compared with albumin in PICD, and in basically terlipressin has been used with a dose of 3 milligram, and albumin has been used with a dose of 8 gram per liter of fluid removed. There were no changes in the plasma renin concentration, aldosterone, serum creatinine, and the mean arterial pressure noted between the two groups. Similarly, a study comparing terlipressin and albumin was published from Vijay Chandigarh, and there was no difference in the incidence of plasma changes in the plasma renin activity, aldosterone, or any other complication related to PICD in the patient who received albumin as compared to the terlipressin group. Noradrenaline similarly has been compared to albumin. Noradrenaline has been used as a continuous infusion of 0.5 milligram per hour and titrated in the early steps of 0.125 milligram per hour to gradually increase the MAP by 10 mmHg and maintain the similar level for next 72 hours. There was no difference which was noted between the sodium level, acute kidney injury, and the plasma renin activity in the patient who received albumin versus noradrenaline. Midodrine has been also used as in the prevention of PICD. Midodrine and albumin has documented in 2 studies. These studies by Aprendot, they basically showed that significant increase in the plasma renin concentration and aldosterone level in patient who received midodrine as compared to the patient who received albumin. However, a study by Dr. Virender Singh, they basically compared albumin and midodrine. They basically showed that the changes in the plasma renin activity, aldosterone, serum creatinine, and sodium level was similar in the patient who received albumin as compared to who received midodrine. To compare the different modality which are available for albumin, there are a large number of trials present. However, there's a cost and the need for IV infusion. Terlipressin noradrenaline has shown efficacy similar to the albumin. However, the data is from the small pilot study for noradrenaline. There is need for continuous IV infusion and admission. Midodrine efficacy is still controversial. It is less studied, but has a good bioavailability, maintains a MAP effectively, and can be given in daycare or outpatients. So coming out to our data, this was a study done in cirrhosis with ascites for the prevention of PICD. They basically use 3 limbs: albumin plus terlipressin, midodrine. A mean volume of ascitic fluid tap was 5 liter, 5.2, 5.3 liter in each arm, and the dose of albumin was 40 grams in each arm. The incidence of PICD was comparable across the whole cohort, with the incidence of PICD being 25%. It was non-significant between the groups. However, the complications were lesser in the midodrine plus albumin group, that is the incidence of hyponatremia, acute kidney injury, were lesser in the patient who received midodrine as compared to the patient on terlipressin or albumin alone arm. So we also studied the incidence of PICD in acute and chronic liver failure patients, and we introduced the concept of modest volume paracentesis. ACLF patients are traditionally different from normal cirrhotics. They have a higher degree of systemic inflammation. They have higher endotoxemia, increase in nitric oxide level, and higher hypercytokinemia, increase in bilirubin, which impairs the cardiac inotropic function. There's arterial hypotension, decrease oxygen delivery, and there's a state of systemic vasodilatation, decrease in systemic vascular resistance, increase in intrahepatic resistance, increased portal pressure, and a state of vasoconstrictor hyporesponsiveness. There's underlying state of circulatory dysfunction in patient with ACLF. There's an increased renin-angiotensin aldosterone system, increase in plasma renin activity at the baseline, and increased stimulation of the sympathetic nervous system. So the study basically compared the patient who were tapped less than 5 liter, and the N was 40 in each arm, and the mean volume of fluid tap was 4.1 and 4.1 liter in each arm, with a baseline plasma renin activity of 23 at the baseline. We showed that the incidence of PICD after even modest volume of paracentesis with albumin was very high, that is 30%, and without albumin it reaches up to 70% in patients who were tapped without albumin, even with less than 5 liter of ascitic fluid removed. Similarly, the incidence of hyponatremia, hepatic encephalopathy, and acute kidney injury were higher in patients who were tapped without albumin as compared to patients who received albumin. We showed that the plasma renin activity of 25.5 nanogram per ml per hour at day 3 basically predicted PICD at day 6 with a sensitivity of 65 and specificity of 70%. Coming on to the way forwards, there's current problems with the existing definition. The value of 4 nanogram per ml per hour, which has been taken to define PICD, has been defined on 36 healthy volunteers, which were on 50 millimole a day of sodium diet for 7 days. The mean value of healthy volunteer is 1.35 with a standard deviation of 0.94, and the range is 0.1 to 4. However, the patient with cirrhosis and refractory ascites have a higher renin-angiotensin aldosterone system value, so the value of 4 nanogram per ml may not hold. And the current definition is based on the plasma renin activity to rise by 50%. So there are technical difficulty and requirement in measuring the plasma renin activity. There's a cautionable benefit in the value of plasma renin activity in patients with refractory ascites. There's additional cost, and the clinical data has been used to define the PICD. So clinical endpoint should be developed to define a PICD. Clinical neurohormonal markers may be identified to identify the PICD early. There's need for to redefine or revisit the cutoff of PRA of 4 nanogram per ml per hour, and the role of cardiac dysfunction, that is cardio markers such as NT-proBNP, needs to be defined. The combination of vasoconstrictors in large volume paracentesis need further evaluation, and patients who have ACLF and underlying SVP, underlying kidney injury, or having a high MELD score that may be more than 25 should be managed differently from cirrhotics during paracentesis. To conclude, PICD is associated with a higher incidence of morbidity and mortality. The hemodynamic changes appear earlier as compared to the clinical manifestation. It is the accentuation of the systemic vascular resistance and the decrease in the effective blood volume and the vasoconstrictor hyporesponsiveness, which basically drives the pathophysiology of PICD. And plasma activity of more than 4 may not be helpful in diagnosing a PICD in sick patient whom baseline PRA is already very high. Albumin reduces the incidence of PICD significantly. Terlipressin and metronidazole have been shown to show comparable benefit in preventing the PICDs.
Thank you, Professor Arora, for your excellent presentation. Now, I would like to invite my friend, Professor Gamal Shiha, to continue this session.
Professor Hasmik, maybe you can proceed. Sorry,
What happened? Hello, Professor Tavisak.
Hi. So
You want me to proceed, Doctor, or Dr. Hasmik? Proceed.
I would like to invite Professor Gamal Shiha for discussion and closing.
I have a few questions to Dr. Guruprasad, if he is around.
Yes.
Yes, 2 or 3 questions to you while we wait for Professor Gamal Shia. One is, very often you have a patient with cirrhosis who has a high protein and high SAG ascites. And what is your approach to such a patient?
High protein and high SAG ascites, where there is an alternative explanation or where there isn't an alternative explanation?
Sorry?
Yeah, so you were saying, well, high protein and high SAG ascites, yes? And so you need to kind of consider whether there is an alternative explanation for a high protein levels and a higher SAG. And you were texting me as a mixed etiology. I think it's probably more important outside Europe and US, but I told you that the data from my own hospital over 5 years is that only 55% of ascites is due to cirrhosis. So there is always a substantial proportion who have alternative explanation. So from a diagnostic paracentesis, I will do more tests than just the basic ones. If it's clear-cut cirrhosis, I would have said just do total protein and SAG and white count, and that is where I would have stopped. But in these kind of patients, I would have been open-minded and I would do cytology definitely more often because the yield varies depending upon a suspicion. If there is any history of heart problem, then I would do BNP and I would do amylase if you have a risk factor for pancreatic disease. And if there is a TB, which is very few I see, but in your context and areas, you may need to do deaminase as well. So more tests than I would standard day-to-day patient I would do. And you asked me about the management as well, therapeutic paracentesis. Would you give albumin in these patients? and how much would you give? So albumin, even in ascites due to cirrhosis, is still not a closed question. As you presented, your colleague presented quite enough data. We have said in our guidance that until further data is available, we should stick to 20% albumin, 2.5 liters drained, and replace if it is affordable. If it's not affordable, then I would say reduce the amount. If it is just not affordable, replace with your alternative treatment. Because if you include all the studies, 14 randomized controlled trial, including all the alternative diagnosis in one group and then 20% albumin in another group, you save about 56 post-paracentesis deaths out of 1,000 procedure you do. So there is a survival benefit. But you need to have everything else on the other side. If you do smaller group of studies, selected study, and that benefit does not show. And so that is the explanation of why I suggest what I suggest. I'll stop there and then challenge me.
Okay, thank you. Thank you very much.
I have a question to Professor Guru again. Is there any absolute contraindication for paracentesis?
I would say, if it is not in the interest of the patient, that's all I would say. I mentioned that if you are bleeding from everywhere due to DIC and you still feel a diagnostic paracentesis will give us an etiology, then you should still go ahead and do it using just a green needle, injection needle. But if you feel that it is going to do more harm than good, then you probably would say that DIC will be one place where I would say an absolute contraindication. All the rest are relative. I think there have been debate because most of the studies done on paracentesis have not included people with SBP, have not included people with hepatorenal syndrome or raised creatinine. And people think that they are contraindication, but there is no scientific logic or evidence-based which stops it. But you can see the logic with the SBP is that they have more tendency to develop renal dysfunction, and then you add it to the post-paracentesis circulatory dysfunction, you might really make things worse. That is the theory. But at the same time, opposite argument is that if you have got a pus in the abdomen, if you ask the surgeons, they'll drain it. So why wouldn't you drain an infected fluid? So there are argument pros and cons. I would say there is no absolute contraindication. Take individual patient circumstances into consideration and then make a decision.
Thank you. There is question to Professor Arora. Which vasoconstrictor is preferable, telepressin or other? Thanks. Professor Arora?
Yes. Usually
Yeah.
we use a combination of a metodrain to maintain a particular level of MAP that is usually above 75 and a combination of albumin to prevent PICD. Telepressin, if there's no obvious contraindication, can be used as a bolus before TAP.
Professor Arora, which one is preferred according to your study? It seems that any vasoconstrictor is not different.
Preferable.
Okay, thank you. Any comments from panelists or any comments? There is no any, sorry. One more. Okay. Any comments or question?
I want to say something that we in National Liver Institute we did an study to compare the alternatives for albumin in patient with large volume paracentesis. We have compared the standard dose albumin to very low dose albumin, 2 grams per liter, to terlipressin, 3 doses, to midodrine. And we have published it in the Egyptian journal. And we found that all of them are comparable. So in areas in which there is no, we can't offer the expenses of albumin, we may use alternatives. And also we had compared also starches like hysterine. I hope all of us read this study. It is useful, especially for middle income and low income countries. Of course, the standard is albumin because albumin is not a plasma expander, but it has also an anti-inflammatory action. But this study, we try to solve the problem in our country.
Thank you.
Thanks a lot.
Thank you. Any other comments?
I would like everyone to remember that just about a week from now, February 4th to 6th, the annual conference of APASL will be held virtually, and I would request our president, Dr. Tanwande, to extend one more time an invitation to everybody in their country. I think they can make some special concessions for people to join, but I would request everyone to take the message to their country and get their faculty students to join the APASL annual conference. Dr.
Thank you,
Tanwande.
thank you, Professor Sarin, for bringing this issue to us. This is just a week from now. We are going to have the biggest event in Asia Pacific liver community for the annual meetings of the APASL 2021. So it's going to be from February the 4th to the 6th of next month. We still have time. You can still have time to join, and it is a virtual event, and actually you can make use of the virtual platform, and then you can access the content on demand after the meetings. There are going to be about 220 speakers, invited speakers worldwide. So please join us at this biggest hepatology event in Asia Pacific region.
Thank you.
If there is no any comments or question, let us thanks to all three speakers for their very nice, excellent presentations, and have a nice evening, everyone.
Thank you.
Bye-bye. Thank you.
Bye-bye. Bye-bye. Thank you. Bye-bye.